Today we're going to be looking at prescribing analysis and research. Prescribing is the most common patient-level intervention in the NHS and covers all sectors of care: primary, hospital, public and community health. It is the second highest area of spending in the NHS after staffing costs. Analysis of prescribing data can take many forms. For example, NHS Digital states, our prescribing team extracts and analyses prescribing data to identify trends and variation and to support national policy. Here we're going to focus on the use of prescribing data as used in my own research and student projects. We're going to look at 5 different projects listed here. We're going to be looking at triptans and depression, olanzapine and weight change, hypnotic drugs and mortality, schizophrenia, and polypharmacy. And the research that I've conducted has been using 2 data sets that we're going to look at. One is the Clinical Practice Research Data Link, known as CPRD, and the other one is the English Longitudinal Study of Aging, known as ELSA. First of all, going to look at the Clinical Practice Research Data Link. This is managed by the Department of Health and it contains over 5 million active patient records and 30 million overall, drawn from approximately 600 primary care practices in the UK. And you can see from the CPRD website that this observational database contributes to research in many areas: drug utilization, pharmacovigilance, pharmacoepidemiology, etc. And the database contains, the structure of the database is shown down here. Essentially, it has details of every prescription issued in primary care and all the medical records as well, together with some basic information about the people seen in general practice. So when you conduct research using the CPRD, you have to generate a protocol, which is quite similar to your research proposals in some way. You have to write a lay summary, you have to talk about this type of study, your study design, sample size, study population, what groups you're going to be comparing, what outcomes and covariates you're going to look at, and what kind of statistical analysis. So in order to access the database, you have to provide CPRD with this information, and they will either say it's okay or they will ask you to revise your protocol. So they want to make sure that they're getting high quality research from the database. We've talked before about observational data, and clearly it has strengths and weaknesses. The big strength of the CPRD is that you don't have to recruit patients or doctors to the study. Analysis is very flexible. You can look at particular drugs or diagnosis or outcomes. You're not interfering with doctors' prescribing decisions in any way. There's great methodological flexibility. You can do case control studies, that is when you take an outcome and look backwards, or you can do a cohort study. And the CPRD subject the data to quality assurance. The weaknesses of the database are that it's not designed for a specific research project. This is routine data. Analysis can be complex because of the data structure. It's essentially everything that's recorded in general practice. So these data sets are huge. And there's limited information about patients and doctors, and also limited information, for example, about things like disease severity. So those are some of the strengths and weaknesses of the CPRD. So the first study that we're going to look at concerns the treatment of migraine with triptans. Triptans are a family of tryptamine-based drugs used in the treatment of migraines and cluster headaches. They were introduced in the 1990s. The first type of triptan that was introduced was sumatriptan, which acts predominantly as a peripheral agonist, and later other triptans were launched which act centrally. And the concern was that these drugs might exacerbate depressive illness. So the object of the study using the CPRD was to compare depressive illness consultation rates between the newer triptans and the sumatriptan treated patients. So how did I go about studying this issue? This graph here shows the methodology that we used. So first of all, we identified people with migraine diagnosis over a 10-year period, and then for a 1-year period, we looked at the rates of prescriptions for people who had been prescribed sumatriptan or the people who had been prescribed the central triptans. And you can see that there was 567 people in this group compared to 152. So quite reasonable sample sizes, although not huge sample sizes. The next thing I did was look at within the same period to see whether it had a diagnosis of depression. And you could see that those who had the older triptans, they had a depression rate of 7.4% compared to 12.5% among the newer triptans. And I did a statistical test, and you can see that this difference is statistically significant. So there was a 5.1% difference, and in the sample, and in the population, this could have been anywhere between 1.8 and 12%. So that does, on the face of it, look as if there is a difference. However, I then separated them into people who'd had their first depression diagnosed after their first prescription in both groups, and now you can see the depression rates are very similar, 4.2% versus 3.9%. So from this we concluded that in fact that there was no effect on the triptans on depression. So you can see how by doing different things within the CPRD you can come up with different conclusions. And also remember that our study was only one part of the story. There's another paper in the literature, a case report, which demonstrates for the first time that acute cessation of long-term triptan use, excessive use, has the potential to induce severe major depression. So the CPRD study is one type of way of analysing prescribing data in relation to a specific outcome. The next study that we're going to look at is from a student project using the CPRD, and the topic was factors influencing weight change in olanzapine treated patients with schizophrenia. And this is from part of the background to the student project. First, there was evidence of excessive weight gain associated with many antipsychotic medications, and particularly olanzapine. We know that weight gain is an important adverse effect linked to long health effects. There have been conflicting results with regard to dose-related weight gains with antipsychotic use, and there have been few studies looking at the long-term olanzapine treatment effects. So there was a good rationale for doing this project. It's also worth mentioning that quantitative studies cannot address all the issues concerning a topic like this, and this BBC radio programme discusses the pros and cons of telling patients about the risks, including weight gain. So these were the aims of the project. First of all, to assess the extent of weight change caused by olanzapine, to investigate any dose-related effects of olanzapine, to look at other potential predictors of weight gain, including age, patient starting weight, gender, and duration of medication. It probably would have been better not to say cause, but to say associated, because it's difficult to establish cause and effect from this type of study. Also, there was limitations of the study. For example, we didn't have information on people's diet or the amount of exercise that they took. This slide shows part of the methodology for the study. So first of all, what we did was find the patients that had olanzapine prescriptions in the database. They had to have at least two, and from this we established the duration. And they also had to have a weight measurement in the year leading up to the first prescription and within 28 days of their final prescription. So these two weight measurements were used in analysis to assess weight change, and the date difference between the first prescription and the second prescription was taken to be the duration of treatment. And patient acted as their own controls. So what we did was we compared patients' weight before and at the end of the treatment. So we didn't have to find a control group of patients. And here we see some descriptive statistics. So there was 130 people in the study. Many people could not be recruited to the study because they didn't have two measures of weight in the database, so that reduced the numbers quite significantly. Of those who had the two weight measurements, we can see here that 33.8% actually lost weight, 27.7% there was weight gain, and for 38.5% there was clinically significant weight gain, defined as more than 7% more than the starting weight. So the first step of the analysis involved scatter plots, looking at each of the variables of interest and relating them to weight change. So the first variable of interest that we wanted to look at was patient's age, to get some idea of how does age relate to weight change. And we can see that there is a weak association. As people age, there's a tendency for weight to decrease. However, we can see that much of the variance is not explained by age. So age there is some association, but it's quite a weak predictor of weight change. The next scatter plot shows something similar. It shows starting weight. So we can see here people's starting weight in kilograms, and we can see the weight change. Again, we see a negative correlation. So those with a lower starting weight down here, there was a slight tendency to put on more weight through the study compared to those with a higher starting weight. Again, it's a very weak association. We can see that because there's a lot of variation in where these points are, individual points are, both up and above and below the line. This scatter plot looks at the relationship between medication duration and weight change. So duration of medication was positively skewed and varied in length from very short treatments lasting only 15 days to over 8 years at 3,000 days. However, most patients' treatment lasted less than 3 years. So remember that a positively skewed distribution is where most of the values are clustered around the left tail of the distribution, and that's what we can see here. So most of the patients have relatively short duration of treatment. And here what we can see is that the scatter graph shows a slight positive correlation. Longer medication duration was associated with more weight gain. So the final variable that the student looked at was dose level. You can see there are 3 dose levels, and we don't find a linear association. So it's not the case of the higher the dose, the more the weight change. So those are all the variables that the student looked at, and you can see that there maybe is some relationship between them, but clearly they could all interact with each other as well. So how do we factor these into the analysis? So the final part of the analysis was to do a regression analysis, looking at how all of these variables relate to weight change. And you can see in the table, we can see all the variables that we looked at: starting weight, age, duration of medication, gender, and dose level. And you can see here the beta coefficient, which is it shows the association, and this can be translated into the R squared, which shows the amount of variation explained by these variables. And these are all adjusted for each other. That's the important thing. It says here adjusted R squared. So we see that starting weight has a relationship to weight change. So does age, and so does duration of medication. Gender and dose level were not found to have an association. So patients' age, starting weight, and duration of medication were significant factors which may cause a change in weight while taking olanzapine, whereas dose level and gender did not significantly impact upon weight change. So finally, how do we put all this together? This is from the discussion. So knowing these risk factors for weight gain, such as younger age, lower weight, can enable practitioners to select appropriate treatments while minimizing side effects. As we mentioned, there are limitations of the study, particularly diet, which we didn't have information on. And also, we didn't look at other medications which could also have an impact on weight change. So you can see from this study how a database can be used to investigate a relationship like the use of drug and an outcome variable. Another topic that I've looked at on the CPRD is schizophrenia. And the reason for this was concern that there was a link between cannabis use and schizophrenia. Now, I have to make clear that CPRD does not contain information on cannabis use. So what I was interested in was the trends in schizophrenia. And the background to this was reports that heavy cannabis use seemed to be linked to cannabis. So I did some analysis for the Advisory Council on the misuse of drugs, which they reviewed in 2008. So the background to this study that I conducted was an earlier study that suggested three things. First of all, an elevated risk of developing schizophrenia or psychosis among cannabis users. Second of all, a substantial rise in cannabis use from the mid-1970s. And C, an assumed risk of lasting for 20 years. So what this would suggest would be during this period we would see an increase in the number of schizophrenia cases. However, there was no data available in the UK which was able to actually see whether this was happening or not. So that's when I was approached to see whether the CPRD would be able to investigate this topic. So we did the analysis, and it was reported in this paper, assessing the impact of cannabis use on trends in diagnosed schizophrenia in the United Kingdom. So here we can see the results of the study. This graph shows the prevalence of schizophrenia and psychosis. We can see the schizophrenia here, roughly stable. Psychosis showing a slight increase, but then stability for a number of years. So explanations other than genuine stability or decline were considered, but appeared to be less plausible. And our conclusion was that we did not find any evidence of increasing schizophrenia or psychosis during the time period. The study doesn't therefore suppose the specific causal link between cannabis use based on the assumptions that I described earlier. We also looked at hospital episode statistics as part of this study, and again found a decline over this time period. So this is just one piece of the jigsaw. There are clearly many others, but it just shows you an example of how we can use diagnostic information to analyse a current issue. And this is what the government's chief advisor at the time said about this study. He said those who claimed there was a link had suggested that there had been an increase in schizophrenia after greater cannabis use. However, the Kiel study did not find any evidence to support this idea. Let's return and look at some work on prescribing, and this time the issue is hypnotic medications. And I'll just explain a little bit of the background to this. So there's evidence of the adverse effects of these drugs, including the ones listed here. And there's definitely led to concern that they might be associated with increased mortality. However, the evidence was based on a number of studies with small sample sized, and the evidence was mixed. A review by Kripke in 2016 concluded that there was 34 studies which looked at the prescription of these drugs. And in 33 of the studies, there was an elevated risk of mortality compared to people who didn't have these drugs. And in 24 of them, the risk was statistically significant. So there was a need for a larger study than those had been done before. So there was variation beforehand in terms of sample size, age distribution, the length of the follow-up, the source of the drug use data, and particularly the extent of controlling for confounding factors. So these were all factors that led us to do this new, larger study, which would hopefully overcome some of these limitations. In this slide, we'll look at some aspects of the study design. So we identified patients who'd received a study drug in any anxiolytic or hypnotic drugs in chapters 4.1.1 and 4.1.2, excluding barbiturates. And we classified study drugs as benzodiazepines, Z drugs, and others. And we measured all sorts of covariates over the entire study period. So if a person had, for example, asthma, it could occur anywhere over this study period. Probably looking at it before getting the study drug would be better, but it was very complicated to do that, so we didn't do that. So we had these groups of people being prescribed these drugs, and then we matched them on age, gender, and practice to patients who had not prescribed these drugs. And what we were trying to do was evaluate two different models. Was it the case that the prescriptions lead to illness and then greater mortality, or is it the case that people who are already ill are prescribed these drugs, and that's what leads to greater mortality? So what we do is created a model which would try and tease out the effect of all these variables. And we're limited because it is observational data. Obviously, a randomized controlled trial would be the best way of looking at this issue, but for a whole variety of reasons, that's probably not going to happen. Before I show you the results, I want to just have a look at what somebody commented on the paper after it was published, and it relates very much to the previous point about, is it the prescriptions or the illness that are causing increased mortality? And the author of this comment on our paper wrote that observational studies, such as this one, have limited ability to address the profound selection biases that go into determining whether a patient receives the drugs, an anxiolytic or hypnotic, and therefore should be considered as the most exploratory level of evidence. The authors of this study did make concerted efforts to address confounders, but their ability to adequately do so is in doubt. Studies such as this should be properly presented as extremely exploratory and published in lesser journals or as letters to the editors, with a suggestion that more serious investigation takes place. So you can see the concerns that people have with observational data of this kind. However, it's not clear that it is possible to do a serious investigation of the type mentioned, which I can only think would refer to a randomized control trial. In terms of observational data, as the author says, we did go to extreme lengths, as you'll see shortly, to try and control for the issues that she is concerned with. As we're going to be looking at an observational study, let's just have a review question. Which one of the following is not true of observational studies? Is it A, differences in outcome are only observed after a particular therapy has been opted for? B, researchers study the effects of a treatment without trying to change who or who isn't exposed? C, patients are assigned to an active or control group by chance? Or D, observational studies cannot help inform probable cause and effect associations before randomized data are available. So the question asked, which one of the following is not true of observational studies? And the answer is C. It's not true that patients are assigned to active or control groups in observational studies. So observational studies and randomized controlled trials are the main types of studies used to evaluate treatments. In RCT, patients are assigned to an active or control group through randomization in order to reduce errors and bias. On the contrary, observational studies do not require randomization. Although RCTs are considered to be more reliable than observational studies, meta-analysis that have looked at this do not show systematic differences in the estimates of effects. So now let's begin to look at some details of this study. This was a retrospective cohort study using the UK General Practice Research Database, as it was called then. And retrospective cohort studies are a type of observational research in which we look back to see whether the risk of a disease was different between exposed and non-exposed patients. So we had data from 273 practices, and they were followed up for an average of 7.6 years, with a range from 0.1 to 13.4 years. And the sample comprised over 100,000 patients. So compared to previous studies, this was a very large sample. And we identified exposed patients by incident drug use for any drug except barbiturates in BNF chapters 4.1.1 and 4.1.2. One limitation of many of these types of studies is that they only measure the number of prescriptions that people have, not how much drug they're getting, and they don't take account of dose either. To get around this, what we did was we quantified people's drug use in terms of defined daily doses, which is something that's been developed by the World Health Organization. So defined daily dose is the average maintenance dose per day for a drug for its main indication in adults. So using this, we defined all people's drug use in the study in terms of how much drug use they had, 1 to 30 DDDs, 31 to 60 DDDs, 61 to 90 or more than 91. These correspond to the duration periods for being prescribed the drug. So we were able to look at exposure in terms of how much of the drug they were prescribed. The other important facet of this study was the control for comorbidity. As we've seen, this is a big issue in observational studies, and if, for example, one group has much more illness than the other, then this could be the effect of increased mortality and not the drug. And it's clear that in this study, when we look at people who were exposed to hypnotic drugs and those who weren't exposed to hypnotic drugs, that there is a big difference between them. So you can see there's a significant difference. They had more arthritis, more of all sorts of illnesses that could be leading to increased mortality. And this was the issue that we had to contend with in analysing the data. Seen that there are significant differences in the prevalence rates of these various conditions between the exposed and the unexposed cases. The next thing to look at is whether they affect mortality, and we can look at this by looking at the hazard ratio. The hazard ratio is the ratio of the hazard rates corresponding to the conditions described by two levels of the variable. For example, asthma, yes, no, cancer, yes, no. For example, in a drug study, the treated population may die at twice the rate per unit compared to the control population. And in this case, the hazard rate would be 2, indicating higher hazard rate of death from the treatment. And we can see here that several conditions do have higher hazard rates. For example, all the ones shown in bold, cancer, CHD. They're not massively higher. They're all about 30% higher. However, these are all statistically significant. There are a couple of exceptions. We can see sleep disorders, arthritis and anxiety are all associated with lower hazard ratios. What we're primarily interested in is the effect of the hypnotic drugs. We saw in the previous slide the effect of the covariates, and now what we're going to look at is the effect of the drugs themselves. And we can see the defined daily doses going from no drugs to more than 90 defined daily doses during the first year. And then we're looking at the hazard rate during the entire observation period. And what we can see is that the defined daily doses, the number of hypnotic drugs, there does seem to be a linear association. So the more drugs that you have, and the higher the hazard ratio. And these hazard ratios are very high. Do you remember in the last table we were looking at hazard ratios of 1.5. Now we're looking at hazard ratios 2, 3, 4, 5. And in the fully adjusted model, we can again see this their effect. So there does seem to be a dose effect association, even when we're controlling for all the other illnesses that people have. In the third and final model of our study, the exposed and the unexposed samples were further restricted to those who had survived for more than 12 months. We can see that here. So we only looked at people who'd survived after the first year. This is to reduce the likelihood of bias arising from the prescription of drugs to those who were already very ill. And what we can see here is, again, we see significant hazard ratios lower than in the last model, but still quite strong associations. And there's a dose effect in the age-adjusted model, maybe not quite such a dose effect in this model here. So using defined daily doses to quantify exposure to study drugs allowed us to combine the effect of different drugs in a way that is not possible by counting prescriptions or numbers of pills. So to summarize, we found evidence of association between all three classes of drugs and mortality over an average follow-up period of 7 years among over 100,000 people, matched for age, gender, and practice. And these associations, which all followed a dose-response pattern, remain highly statistically significant after adjusting for a wide range of confounding variables. So in the discussion to the paper, what we state is that the results of models in which exposure was restricted to the first year after recruitment suggests that much of the excess mortality risks arise early in the exposure period, and this is the key point, but remains significant even after discontinuing study drugs. However, we did not examine temporal risk trajectories in detail. So this was really the first major study to try to control for factors which other studies had not been able to do. This slide shows a piece of the analysis that we didn't report in the paper, but what we did here was we looked at people who had studied drugs, but the doctor had not recorded any diagnosed condition in their medical notes. So what we see here again is quite a strong dose effect with no drugs down here going up to more than 90 defined daily doses, and here we see the data for people who do have medical conditions. So they generally have higher association, higher hazard ratios, but even in the people who have no conditions, there is a dose effect. So this shows the final piece of analysis that I would like to show you from this study. One of the hypotheses that's been suggested is that it's not the hypnotic drugs, but it's the sleep disorders or anxiety that are somehow causing higher mortality. So here what we did was we only looked at people who had sleep disorders or anxiety. So that's this group of people here, but they had no other medical conditions. And again, we see the hazard ratios are very high, and again showing a dose effect. So I hope you can see from this study that we were able to use the prescribing and diagnostic information to test out various hypotheses about the relationship between hypnotic drugs and mortality. Another study that we've conducted is looking at prevalence and predictors of polypharmacy, and for this we used the English longitudinal study of aging. This is a study that collects data on people aged over 50 to understand all aspects of aging. More than 18,000 people have taken part of this study since it started in 2002, with the same people re-interviewed every 2 years. ELSA collects information on people's physical and mental health, well-being, finances, and attitudes around aging and how these change over time. So we've been looking at the polypharmacy data component of ELSA, and one of the things that we've been doing is described in the objectives of this paper. What we wanted to do was we wanted to see whether, apart from ill health, are there other factors such as people's wealth and behaviour indicated by their smoking and alcohol, and also to what extent does body mass index relate to polypharmacy and hyperpolypharmacy over and above people's ill health. So the results of that study were published in the BMJ in Open in 2018. I just wanted to show you some of the data from this study, also just to illustrate how we went about presenting the data. Before I presented the more multivariate analysis in the study, I thought it'd be interesting for readers to see how each of the things that we looked at related to polypharmacy. And what we can see on this graph is the correlation between various factors such as whether you have long-standing health conditions, whether you have poor self-rated health. And the higher this bar, the stronger association with polypharmacy. So there's no surprises to see that the top predictors of polypharmacy are long-standing health conditions, poor self-rated health, and older age. It may be slightly less expected to see that people with a higher BMI also have higher prevalence of polypharmacy, and also those with lower wealth. So it's interesting that people with lower wealth are more likely to receive more drugs. Gender doesn't seem to have much association, and perhaps surprisingly, people who smoke and drink have lower levels of polypharmacy. In another paper, we've been looking at the composition of polypharmacy using the ELSA datasets. Surprisingly, few studies have examined the composition of polypharmacy in detail. One Swedish study reported that analgesics and psychotropic drugs were commonly taken by participants with polypharmacy, and that these drugs make a significant contribution to the overall prevalence of polypharmacy. And that doctors should be alerted to the fact that tricyclic antidepressants should be avoided in the elderly due to the enhancements of anticholinergic effects. So this is from the introduction of the paper, where we state that many CNS medications are considered potentially inappropriate. However, these medications are common in polypharmacy. So the aim of this paper was to determine the prevalence of CNS drugs, and we also wanted to see whether the factors that I've just talked about are also associated with CNS drug classes. In this slide, I'm just looking at some of the findings from the study, and what we can see are relative to people who don't have polypharmacy, that is 1-4 medicine. If you have polypharmacy, you're almost 4 times as likely to have non-opioid analgesics, almost 6 times as likely to have opioid analgesics, and 3 times more likely to have TCAs, and 2.2 times more likely to have SSRIs. So although there's been suggestions of this in the literature, this is the first time that really shows the high magnitude of the association of these drugs within polypharmacy. One explanation offered for the association is that pain commonly associates with other chronic conditions, and polypharmacy may be used to manage these morbidities. However, this approach may increase an individual's exposure to the adverse effects associated with analgesics, as polypharmacy increases the opportunity for drug interactions and adverse drug reactions. And in relation to the previous study that I mentioned, we can again see that wealth is also a significant factor in predicting receiving these drug classes within polypharmacy regimes. So just to summarize, I've shown you some examples of prescribing analysis, and I think it's worthwhile knowing that knowledge of real-world data sets, such as the ones that I've talked about, are increasingly useful to pharmacists in many settings, including the NHS, the pharmaceutical industry, regulators, government departments, and so on. So some of you will be doing health information projects, and this slide just summarizes the range of topics that I've been looking at with students over the years. So you can see all the issues here, a very wide range of issues, and students who do these projects learn how to analyze prescribing and health information, many of which are relevant to current issues in pharmacy research.